Good evening, everybody. And as you are aware, today is going to be a very busy day for me because after this, I have got from 7 o'clock to 9 o'clock PG update. So I'm not going to do my normal talk about all those things and we will directly start our session. I am waiting for Athol Wells if he can make it well and good. Otherwise, we have Murli Mohan sir and we have got Sujit Rajan sir. We have got Vimal Raj sir. We have got Ritu and Mithun will be joining. So let us start.
You want to drop Athol a message?
I joined. Can you please call him on WhatsApp if he can?
I will tell him. I will.
Yeah. So I'll move on to my first case, which is of 42 years old man who is from Kerala, who works as a flat keeper in Kuwait, who is not having any comorbidities. He presented to us with insidious onset of dyspnea on exertion, which was grade 2, now presented with grade 3, and associated dry cough for 3 months. He had associated weight loss also, predominantly dyspnea on exertion and weight loss, joint pains present, stiffness of fingers present, discoloration around eyes and mouth. I don't know how much relevant it was, but it was his presenting complaint. So I have put he had history of allergy to dust, but no history of any exposure as such. History of lung disease in mother. Mostly it was asthma. That's what I believe. He was evaluated at another center and he had bilateral mid and lower zone reticular sedos, which was treated. He was treated as a fibrotic NSIP and steroids, with which he improved transiently, but he didn't feel much improvement, so he decided to come here. So there were 2 CT scans which were taken outside, which we will be dealing with in a short while. When I examined him, his saturation was 95%. And other examination was normal. He had some crepitations, but nothing significant. ANA profile was negative, and so was myositis profile. Did I share the AC level? Yeah, AC level was 63. I have put calcium level also because calcium is relatively high for an Indian 10.4 who is not on supplement. So that was slightly higher side. Anti-CCP and RF factor was negative. So I will stop sharing now and I'll give the thing to Sir, Vimal Raj sir. You are muted, sir.
Okay, good evening. Thank you very much. So I'll start off and perhaps show you the most recent scan first. So this is the scan that we are talking about. This is from July 2024. If we just first concentrate on the mediastinal windows across here, you're seeing some small volume lymph nodes. These are not significant. There are some lymph nodes in the mediastinum, some lymph nodes in the hila also. One of the prominent ones in the hila here. Again, short axis is not that much, but the long axis is around 2 by 1.5 centimeters. No other lymph nodes. Upper abdomen also did not have any lymph nodes. Now, when we look at the CT, I'm going to show 2 comparative CTs together. What you're looking at is a CT scan from May 2024, and this is the CT scan from July 2024. So this is the old one and this is the new one. And what we can see across here are these diffuse interstitial changes, which are involving both the lungs, more towards the lung basis, bronchocentric in location. There is associated traction dilatation of bronchi going all the way out to the periphery, but the subpleural aspects are relatively spared. There is no honeycombing. There are no cystic changes. We don't have any expiratory imaging, but minor areas of what looks like mosaicism that we can see in here. When we look at the fissures, there are some areas of nodularity, for example, across here, very minor nodularity, but these are not very classical of what you may see in sarcoid, but small areas around the areas of fibrosis. So this is looking like a fibrotic interstitial lung disease. This is inconsistent with UIP. I would have put top three differential would have been CTD, ILD, NSIP, fibrotic NSIP pattern, HP, and sarcoid would be there in the order of perhaps NSIP at the top. Second would be HP, and third would have been sarcoid.
I think that makes simpler. 1 second. So we had seen the CT scan. His pulmonary function test was relatively okay, like moderate restriction, 66%, 70% FEV1, 66% FVC. He had DLC of 68 and 51. He didn't have any desaturation. And Ritu madam, if you can just talk about this is we did a transbronchial lung biopsy, and these are the images from the I believe I did from the left lower lobe because I felt that was the maximum affected area. Yeah.
Okay. Could you please share the slide?
It's not coming.
No.
1 second. Is it coming now? No,
Yes, it is.
it is. Okay. Right. Now you can see, ma'am. You are muted, madam.
Okay, can you hear me?
Yes, yes.
Okay, yeah. So here what we can see are multiple non-caseating, well-defined epithelioid cell granulomas, which are present. And what can be seen at this power is the presence of giant cells, the presence of a kind of the hard granulomas, which can be identified even in this section, even in the next one also. Each granuloma is a pretty hard granuloma because it's got a layer of a fibroblastic ring kind of this thing around it. And apart from these granulomas which are there, there is interstitial inflammation, there is interstitial widening, and in this slide you can see the the components of the granuloma, the cells, the multinuclear giant cells, the epithelioid cells. And I believe the last slide, there's one more slide after this, which is showing the same, the non-caseating epithelioid granulomas. So with this, the only diagnosis which can be given on the biopsy alone would be a granulomatous pneumonitis, and like to rule out for sarcoid for this patient.
Yeah, that's what my pathologist also said, and that is why I'm discussing this patient. So now my experts, my questions for his special stains came negative, so his Manto is negative, and his AFB, smear, gene expert, everything is negative. And I have started him again on 40 milligram of prednisolone last week. He was given some 16 milligram of methyl prednisolone, but I changed it. And now my question is the radiology is in favor of HP or sarcoidosis. I believe sir has very clearly said that he will put HP in before sarcoidosis. And granulomatous inflammation is it sarcoid or HP? Madam wants to say it. She will put sarcoid first, and that's what my pathologist also said. So my question to the panel is what are we dealing with, or does it make any difference to make a diagnosis because the treatment is same, and should I add any more drugs? I'll stop sharing.
Basically, I don't think the granulomas, I mean, I will wait for Murli also to say, but those granulomas don't look like what we see in HP. I mean, there are too many, they're very solid granulomas. It doesn't look like a malignancy on the scan either, or a lymphoma. So I would definitely zero in on the diagnosis of sarcoid. Do you have serial lung functions, Asmita?
I think for the previous one I showed now that my PG has mentioned in somewhere
Can you
here.
bring the history?
Yeah. So it was she has written it was 11% DLCO, which became 68% after receiving some from May to July. Yeah, 3 months of steroids, and it improved.
What was the vital capacity? Before
that we have not mentioned. It was just documented by somebody. So
okay.
Our vital capacity is 66, 70.
Percentage predicted, right?
Yep.
So it's gone up from earlier with those with the prednisone.
I think so. Yes.
Improved,
Yeah.
the
He has
DLT.
improved with steroids. The other point which he if you see, I put a long history in which he had significant weight loss, which is also may not be classical of HP. And he had joint pain, which is also not classical of HP. And as Madam rightly said, to see granuloma in HP is a task. Like pathologists will be searching for it, not like we will get plenty of that. That is the thing. But however, she told that it is not naked granuloma, and she cannot say it is sarcoid also, like granulomatous inflammation.
You're losing weight on steroids, Asmita?
No, before the presenting feature was
sure. So he's gaining now. He's not losing.
Now he's not losing. Yeah, now he's not losing.
Top steroids or still on steroids now? He
was on, when he came to me, he was on 16 milligram and 8 milligram. But the doctor sent to me one question to Vimal Raj sir. Sir, did you feel the CT is worsening? The doctor, treating doctor referred to me because he felt there is no improvement and he was scared.
On imaging, there isn't any worsening. Almost the same, if at all, very minimal difference, but no worsening. No.
Sure. So he didn't worsen on steroids, but I felt it was a half-hearted treatment. Only Mohan sir. You are also muted, sir.
Mulli, we can't hear you. I think your audio
gets his audio. Why do you think it was half-hearted treatment? 3 months of steroid and he felt
No, I would have treated with, he started on 16 milligrams, sir. I would give more
16.
1.6.
Yeah. But then the Sarkort study from Sejal suggested 20 is as good as 40.
Yep.
I guess 16 is not too bad.
Sure. I agree.
Yes, I do believe that 16 milligram methylpredate should be enough to affect the response.
Sejal is here also. Great.
Most of the patients, and there may be other reasons, maybe compliance, adherence, and some patients will require a higher dose, but those are very few and far between. Okay. And going by the CT, didn't look like sarcoid.
Yeah, CT didn't look like sarcoid. Yeah.
That's true.
That's true. CT didn't look like sarcoid, and the histopathology didn't look like HP. That is another problem.
Correct.
So I was also surprised when I saw the report, because maximum I was expecting some fibrosis. Was there any fibrosis? Because my other question was, is there any need of antifibrotic? Did you see any fibrosis in the slides, ma'am?
If I look at the granulomas, ma'am, each granuloma is showing a definitive ring of fibroblasts around the ring. So we may be progressing in some other area also.
Okay.
Yeah.
Can I come in there, Dr. Asmita? I'm sorry.
Yeah, sure.
Yeah. So I think, pathology trumps everything. So while Dr. Vimal Raj did bring sarcoid into the DD, he put it down a little more. But once you have this kind of supportive histological evidence, I think sarcoid comes right on top. And as you correctly mentioned, joint pains, a slightly higher than expected calcium, a kind of borderline ACE level. I think sarcoid definitely before anything else. My question would actually be, there were just 2 months between the two scans. So it's not going to tell us enough about progression. Sure. But I'm just wondering if, rather than discussing, should we add an antifibrotic at this stage, you want to ask, should we add an immune modulator at this stage?
Sure.
I think where CT Vimal would would trump histology is when you're seeing such definite evidence of fibrosis. So I think there's no doubt that there's fibrosis, but I'd like to see progressive fibrosis before I added an antifibrotic. And I think I would first add maybe methotrexate, cut down on the dose of steroids, as Sujit was just saying. 20 milligrams of pred is likely to be enough, but add on, methotrexate or MMF, which you prefer working with. And then consider repeating a CT lung functions in 3 to 6 months. My anticipation is DLC has already improved. It's likely to improve further. And then we can take a call on the antifibrotic.
Yeah, I am sorry, I forgot to give very useful information. So he is working as a security guard in a flat in a Gulf country. And when I specifically asked that, is there pigeons there? She told there are plenty of pigeons and he doubles as a cleaning staff. So he is exposed to droplets of those particular pigeons excreta. And I don't know now. Now it is like it's all combined. So I think we are not reaching anywhere. We'll just leave it. We have got Rajan sir. We have got a guest over here, and he is Dr. Amila from Sri Lanka. Would you like to add upon something, or I'll move on, Dr. Amila? Yeah.
Hi, good evening, Mashmita. Thank you so much for the invitation, and it's a pleasure to join you from Sri Lanka. It's my first time. I think we met Dr. Rajan and did the PACS, and it's an excellent program. Again, actually, I think as a principal, I would agree with all the speakers. Our radiological, it is inconclusive. The patterns are. I mean, we don't have any 50% confidence on the radiological diagnosis. Histologically, I think we are more towards the sarcoidosis. And when you consider the histology as well as the radiology with all the rest of the information, I think sarcoidosis comes as our first differential. I'd agree with you. And however, I think most important aspect is we have to assess the longitudinal behavior of this disease. I think as Dr. Murali suggested, I'm totally agreeing with starting on a second line immunomodulator like methotrexate and have a continuous follow-up. And at the same time, even though it is our working diagnosis sarcoidosis, we should, I think, encourage this person to avoid the exposure to pigeon as much as possible.
I did
so
that.
I think we
I
have to
did
assess
that.
the longitudinal behavior of the disease very carefully.
Sure. And Vimalraj sir, one last point is now I have restarted even 40 milligram as advised by Sajal and sir. I will decrease it fast. Should I repeat a CT scan after 6 months?
Yeah, I just before he comes in, I don't think you need to decrease it fast. You can do it slowly. You're on a lower dose now, and you can just go slowly down on that. But any comorbidities, age again, Asmita, how much was
It's 42.
42. So you would be concerned about giving him steroids too long.
Diabetes,
yeah. And so you would like to bring it down soon.
Sure.
And I'm on methotrexate. I agree with that. Without evidence of PPF, radiologically, I wouldn't be in a rush to start an antifibrotic.
Sure.
Especially since it's sarcoid.
Yep.
Because that also commits him to lifelong treatment at 42, which is a
long time.
Yeah.
Sure. We'll move on to the next case, which is also by me. So this is a 52 years, again from Kerala. He's an ex-smoker. He stopped smoking some 2 years before. He was an ex-alcohol consumer. His background is he had type 2 diabetes for last 10 years. He was diagnosed as chronic liver disease. It was decompensated and he underwent liver transplant in March 2024. I saw him somewhere in June, July, last month, yeah. And history of primary complex TB medicine taken 10 years before. Now, when he came to me, he had sudden onset of cough. He underwent transplant somewhere in March and he was doing perfectly all right. Then maybe he developed some viral infection or I don't know what, but he came for 1 week increased breathing difficulty. Till now, nobody has given him a diagnosis of anything other than his liver problem. He had a history of exposure to pet animal at home, but it was cat or dog and biomass fuel. But he had his mother told me that his father passed away, who was a doctor, because of idiopathic pulmonary fibrosis. So this was the history. And when I examined, he was 96% on room air and bilateral Velcro crepitations. No other systemic abnormality I could find out. He was as a part of liver workup. He was his ANA screening, ANA profile was done. ANA was 3+ speckled, but the profile was negative. ESR was not done. CRP was normal when I saw him, and OTPT is also normal. This is like a post-transplant. Now his CT scan, which was taken when I saw him, is what I'm going to share.
Asmita, is he on any
He's
pneumotox?
on I think he's in tech. He's on tacrolimus and he's on very small dose of steroids, 5 milligram or something. Yeah, that's it. They didn't give MMF or anything. Yeah.
Okay. So this is the CT scan of this gentleman, and this CT scan is from July 2024. We will start with the mediastinal window again, not showing much in terms of any lymph nodes, nothing untowards. All these surgical clips in the liver in keeping with his recent transplant. So no lymph nodes, etc. But when we look at the lung parenchyma, we are obviously seeing these interstitial changes more towards the periphery of the lungs. Early areas of honeycombing are starting to develop in these small cystic changes in the subpleural aspect. A lot of it is bronchocentric, going from the center to the periphery. And you can see as we come down to the lung basis, it is traction dilatation of bronchi, patchy ground glass, and then further dilatation of bronchi. You can see it's very, very asymmetrical in appearance. There's no nodules. Cysts are only seen in the subpleural aspect in the upper lobes rather than in the lower lobes. No obvious mosaic changes. We do not have any expiratory scans on him. But you can start to see some subpleural areas of disease that we can start to see across here. So this all pretty much looks like a fibrotic interstitial lung disease as a process which has got both active as well as a chronic component within it. The pattern is not fitting into any one particular thing, and that's why I was worried whether this is related to any drug toxicity that we are looking at. But this is going towards what may become an IPF. But at this point in time, I think it is very indeterminate in what we are seeing in terms of pattern.
So I would like to add upon on this that as a part of workup, now they will do this abdominal CT scan before doing transplant. I didn't share those things, but he underwent actually a CT scan abdomen in which the basal cuts were seen, and I could see fibrosis. That's why I told that nobody commented about that earlier, but it was there. It is not progressing, and because it was only basal cuts, I didn't share with you. But it is not because of his current drugs. That's what I would like to highlight. And now
full lung
yes, sir.
function wasn't done either, Asmita, pre-transplant?
I did. Pre-transplant, maybe only spirometry we do, but I think he didn't do that also.
Oh.
So this is what his lung function at present is. He desaturated from 95 to 89. He covered only 360 meters. His DLCO was 68% of predicted and FVC of 73% of predicted. He didn't have pulmonary hypertension. So my question is it familial IPF? Because father also had, however, father developed when he was 70s. He is in 50s, or it is cirrhosis related. This is not the first case of cirrhosis which I am seeing with interstitial lung disease. I had seen plenty of, at least I can say plenty. And actually I look for it. That's why I'm saying plenty of cirrhosis and IPF combination. And is there any genetic test which I should be ordering? And should we try antifibrotic in a patient who has just undergone transplant? So these are all clinical, practical questions which I would like to ask.
Maybe Sejal and Murli want to go first.
I think with liver involvement and lung involvement like this, with the family history, the first thing we think of is the short telomere syndrome.
Yeah, I also felt
because that. Did he have any bone marrow issues like any cytopenias, anemia, cytopenia?
Presently his counts were around borderline lower side, but I'm not sure. It's like because it happens in cirrhosis also. So I'll keep a watch on that. Yeah, all three combination happens. You're right. Yeah.
So short telomere syndrome will be my prime possibility. Because the lung disease seems to be slowly progressive and chronic. So it must be part of the familial lively syndrome. Otherwise, in another setting, I would also consider GVHD because sometimes isolated lung GVHD can occur after solid organ transplant.
Yeah.
The pattern, I'm not very sure whether it fits there or not because the pattern is really indeterminate or going more towards, I would say, fibrotic NSIP with some ground glassing and reticulation. But in this case, yeah, with the family history liver involvement, short telomere syndrome will be first. And for that, we can look for mutations in the telomere genes and we can actually do the telomere length. to find out whether it is indeed fitting the bill.
Is there any that TERT gene or anything? What we are supposed to do, sir?
Yeah,
Do
so
we-
RTL1, TARN, TRT, TRC, these are the telomere
Yeah.
related genes. And
Yes.
then the telomere length itself can be like it can be assessed by comparing to a age matched control.
Sure.
And but it is still, we are not, like in India, it is not being routinely done, and it has to be a research based kind of an investigation. So we did some telomere length assessment for our post-COVID fibrosis a couple of years back, but we didn't get to the root of it, and we didn't get the results that we were looking for, and we actually left the investigation in the middle. But that can be done. We are now looking at some of the telomere gene mutations in our IPF and HP patients, but not the telomere length at this.
Another reason to do the telomere length, as Sejal says, is how long is he post-transplant, Asmita?
4 months. March he
Yeah.
underwent
So
transplant.
you would probably tailor the immunosuppression if the telomeres were short, because they tend to have more complications with short telomeres with immunosuppressive therapy.
Mhm.
That's another reason to do telomere length testing. And otherwise, I'm surprised that no full lung function was done after interstitial lung abnormalities seen on the abdominal scan, but I guess that tends to happen. It would been good to have the full PFTs, but if you have, for instance, an ILA also on a on the scan, or poor lung function, you are at risk for more complications post-transplant. That one point that Sejal mentioned about GVHD, I don't know. I'm not good at that. And to be honest, I may want to ask Ritu that question. Can pathology differentiate between GVHD and, say, just interstitial fibrosis related to short telomeres?
I'm sorry, I won't be able to help you there because we don't get transplant pathology at my place.
Sure.
Yeah.
Only one answer.
No, so I'd agree with everything that Sejal said. Nothing to add. The only, I think he brought up the very important point of GVHD. I would keep that in mind. But to my mind, it doesn't look like what I've seen. We see a lot of post bone marrow transplant GVHD involving the lungs.
Yeah.
I would still go for familial ILD, short telomere being one of them as my prime diagnosis, because it explains the family history also.
Coming to the second part, I would like to know, suppose if I wanted to start antifibrotic, can we, and which drug?
Most of my hepatologists agree on the commencement of antifibrotics. They only say monitor liver function.
Okay.
So this has been my experience with my hepatologists. I guess if they're really bad, then then the benefit outweighs. I mean, the risk outweighs the benefit anyway. But I think with child PUG 1, 2, 3, we could easily do it. For cirrhosis.
Sure. You want to add something, Dr. Mila? Yeah.
Out of my interest, excuse me, I'm just wondering whether this patient has a premature graying of the hair. That is one of the classical feature we see in short telomeres. We had a patient with, this short telomere syndrome, and he has he has premature graying of hair. I mean, it's one of the features that we should look into. It's a very simple thing.
I agree because I still remember him, and he was not looking like 52. I have to confirm that you are 52. So he was looking very old compared to the age which was given to me. So yes, he had.
The history has to be whether he was graying in his 20s, Asmita. However,
No, that I didn't ask. That is called premature graying. Okay.
And also, I mean, with graft versus hostase, actually, my experience is mainly, I'm sure that Dr. Rajan would add on to this. My experience mainly, it's a bronchiolitis obliterans syndrome. So it's a BOS type. We see quite a lot of mosaicism and AR trapping. And so the pattern is not identical, but I mean, you can't exclude. But still, I think on our MDT, I'm for the diagnosis of familial IPF due to short telomere syndrome. And I'm for starting antibiotics as well.
Yeah, I'll share the screen for Situ's case. Yeah, Shitu, all yours. Please start.
A very good evening to all of you. So I had this interesting case of a 69-year-old female who presented with shortness of breath in 5 months, dry cough since 4 months, dry mouth occasionally, some weakness, no history of chest pain, wheeze or hemoptysis, denied any joint pains or any other CTD associated symptoms. Ma'am, next please. She's a non-smoker, and now this was a very unique part. She had exposure to bird feathers, droppings. She was also overseeing some paint work that was ongoing in her house, and she used to be there 7 to 8 hours per day. She used to live on a farm with exposure to hay, so a lot of exposures. She had no known comorbidities and was not on any regular medications, and she had no similar family history. Her initial spirometry showed a FPC of 56%, and she had a drop of saturation of 4% from 92 to 88, covering 220 meters only. Echo was okay. ANA was mildly positive with a homogeneous pattern, and RF and anti-CCP were negative. So over to Dr. Vimal for the scans.
Thank you. Let me just show that. So I'm just going to start off. We've got 2 CT studies. I'm going to start off with the most recent one, which is from August 2024.
I would request you to take the May one, and then we take the biopsy, and then we take the last scan.
Sure. The reason May one is not great, but I'll take that. Give me just 1 second. So this is the CT scan from May 2024. This is the original scan, and what we can see across here, this is small volume lymph nodes across the mediastinum. Some of them show these spotty calcifications, which suggest prior infections. The patient has struggled to hold their breath during this time, and you can see there is predominantly an expiratory phase scan, and there are lots and lots of what looks like ground glass with some mosaicism within it, suggestive of air trapping, mild interstitial changes, interlobular septal thickening. And as we go down, you can see all the same similar changes. So lots of ground glass with mosaic perfusion, and then patchy areas of subsegmental atelectasis in the extreme lung bases. No, there is this one area, if you look here closely, what you're seeing across here are these small nodules that we can see. This is very indeterminate in the subpleural location. You can see in the soft tissue window also that there are some of these multiple nodules in the lower lobes that we are seeing. These nodules are very indeterminate in nature. Again, if you're looking at a malignancy metastases, you wouldn't expect them to be that well-defined and focal areas. You would expect them to be more very atypical for standard infections that we come across. So on the CT, I would have felt that there's a lot of small airways disease component associated. So with the given history, could this be hypersensitivity pneumonitis? But these nodules are really indeterminate, and we need to look at them a bit more in detail.
Thank you, Dr. Vimal. So subsequently, after this scan was done, we took her up for bronchoscopy, and the lavage was done, which was normal, and the biopsy was done. And I guess this was our pathologist report. I would like to get the opinion from Dr. Ritu.
Yeah, so hello.
Yeah, we can hear you.
Yeah. So when I looked at this, and I looked at 1 or 2 more slides sent by the pathologist, there is a lot of, if you look at it, it's an endobronchial biopsy. There is transalveolar tissue also. The first thing when you see this biopsy, you see that there is a lot of distortion of alveolar architecture. It's completely full. and with inflammatory cells, and they are clearly, they are lymphocytes which look, even at this power you can appreciate. There is some minor necrosis which can be seen. I tried to look for granulomas. At this power I could not appreciate them, but in some other section which she sent me, I could see some amount of hemosiderin pigment, which was seen as brown pigment, which was there in the parenchyma. So that got me also worried of why we are seeing pigment here. So I would not put this down as granulomatous lesion primarily, but I would look for causes of lymphocytic interstitial pneumonitis so much, and put in some special stains to see if there is any perivascular distribution, if there is any vasculitic component there, and the hemorrhage, the pigment which is coming up in the parenchyma, whether that is causing this issue. So that's my input so far in this biopsy.
That's quite interesting to know. So what happened was, after we did the biopsy, she was quite dyspneic. We started her on the steroids, and she took a she just got herself discharged and went home. And we had put her on prednisolone 20 mg. So once she was discharged, the biopsy report came after that. However, we never heard of the patient again till, we took this case up for our MDD in the hospital locally, and our pathologist was really keen that this could be tuberculosis with the necrosis she was seeing. So we called her up again, and at this point, I would request Dr. Vimal to share the scans, and I'll just give an insight that this patient was doing very well on 20 mg, and her son was a compounder, so he reduced the dose himself, and she was on 5 mg, and she was doing very well, and she was very happy.
So what you're looking at now is, this is the old scan, May 2024, and this is August 2024. So 3 months gap, and you can straight away see there is still mosaicism, but the mosaicism has gone down. The background lung parenchyma looks much better than what we had seen before. There still remains areas of air trapping. And as we go lower down in there, you can see these nodular changes. We were seeing them before also, distinct nodules with very irregular margins that we're seeing, and then these peripheral areas of consolidation in the lungs bilaterally. So the ground glass has significantly improved. The lower lobe nodular changes and the consolidation are relatively same. Vasculitis as a differential, the nodules can be seen in them, but the location and the pattern is not very typical of what we are seeing. And these would have expected them to have some different morphology, more nodules in other locations, as well as some change in morphology over a period of nearly 3 months within. So overall, we are looking at something which hasn't changed much in terms of the nodule and consolidation. The background lung, which had the inflammatory changes, have definitely improved.
Could this be, the nodules be some old infective sequelae, and the inflammatory disease was the new part?
When I and the nodules might be representing some infection like tuberculosis, which is coexisting at the same time. But the way that it has cleared up completely, and we did see some necrotizing granulomatous inflammation. Maybe necrotizing sarcoid granulomatosis fit with it. But so with necrotizing sarcoid granulomatosis, you might have nodules, you might have consolidation, you might have a necrotizing pneumonia-like picture. And you will find some necrotizing granulomatous inflammation in that kind of disease. So, form of sarcoid. Nodular sarcoid is a very close differential. So, looking at the steroid response, I would should be considered.
So can I ask Vimal a question? Okay, can you hear me?
Yes.
Yeah.
Yes.
Vimal, did you think, because if you look at the two scans, the first one is really expiratory, and there is a gradient of increasing whiteness as well. So whether the ground glass was ever real in the first place, because the second one, you see the lung volumes have increased so much, both antero-posterior and superior-inferior, and sometimes I struggle because there are some patients who have this exaggerated uh, what looks like ground glass on expiratory, and on inspiratory you realize that it's absolutely bang normal. So I'm just wondering what you thought about it. Was there ever disease in the first place?
So we do have one more prone imaging, which I did not project. And even there, the same difference in terms of the ground glass changes. There is disease. It's not, as you said, it is exaggerated significantly because of poor inspiration. But there were patches of ground glass which were there, which has now got better. I wouldn't say 100 getting better to 20 or 10. It's probably 20 getting better to 5 or 6 in terms of that.
What is the opinion of the panel? As Dr. Sehjal Duria just mentioned that this looks like a necrotizing sarcoid with the pathological and the radiological presentation. What about the pathological signs? What are the stains that Ritu ma'am, what were you talking about? So we did run AFP and the fungal stains which were negative. Any other stains?
Yes. So if you could send me the biopsy over, maybe put in some immunohistochemistry, because the first thing which when I see the biopsy is the lymphocytes, and I think there are a few plasma cells also. So I would really like to put in some immunohistochemical markers to see if I'm dealing with any monoclonality or not. I would like to rule out CD4 and CD8 count and just rule that out first. Because that's the first picture which is coming, and the cells which are looking epithelial like in the background, I'm worried whether they could be just the epithelial cells which are there, which are looking like epithelioid in nature. So I would really, in this case, like to rule out monoclonality of any
Shitu,
sort.
where was the biopsy taken from? Was it just transbronchial or was this an EBUS?
No, it was a transbronchial lung biopsy. So many times, we do encounter patients with so many exposures. How to, really ascertain? Murli sir, would you like to shed light on how do we ascertain which exposure is important, and if there are multiple exposures, which is the inciting one? So sometimes things become very complicated.
Yeah. So I'm going to go back one and say, rather than sarcoid, I would much rather think of HP. You have a history of multiple exposures. You have a history of a person who appears to have at least some degree of differential, it's not a typical triple density sign. You have at least two. You have a significant improvement after steroids. And while the nodules have not changed, I'd expect if it was sarcoid, nodules to have changed, and I would expected better formed granulomas. Something that Dr. Asmita brought up right in the beginning, that you really have to struggle to find granulomas, which is what we are seeing here. No really clear-cut granulomas, no clear-cut giant cells. I would much rather think of HP than anything else. So having gone through that, identifying the inciting agent is very difficult, because multiply you will find a person who's exposed to many things being sensitized to them. It doesn't mean to say it's the disease. So you can do the HP panel for what it's worth. And if you find one is a very high titer, the others are not there, then it may be, worth looking at. But somebody who's exposed to multiple organic antigens, I would probably try and withdraw them all at the same time, and then see if you can gradually reintroduce her to her place of work. I don't know how easy that is, but we've had patients, we've just moved out of that house, moved out of the place. They make a dramatic improvement. And when they go back, you can, often pick up, depending on the time of the year, the season, you may pick up what is the inciting antigen at that point. Otherwise, it's virtually impossible to decide which is it, given the relative non-specificity of a HP panel.
I agree. I guess. So I think, thank you.
Any role in biopsying that nodule?
I was wondering about that too, exactly. So a CT guided biopsy should not be too difficult, may give us an answer. And, I agree with what Sejal said, that we should keep sarcoid nodules in mind. Doesn't explain the rest of the picture, but I would definitely keep sarcoid nodules in mind. Maybe worth doing a CT guided biopsy from there.
Especially because she never had any past history of tuberculosis or infections. So that may explain everything in one diagnosis.
Absolutely, yeah. But especially if you're planning to keep her on steroids, immunomodulation, becomes extremely important to keep TB as a possibility.
Only one doubt, Ritu madam, you were talking about you saw some plasma cells. So, and the nodules are there, and sarcoid in IgG4 is quite similar. So, is the radiology matching with IgG4, Vimal Raj sir?
Not very typical in
Okay.
terms of what you're seeing in the other parts of the lung parenchyma to
Sure.
these nodules. No, it does not.
And one more doubt, you have received the images which I sent today, Madhu sirs, right?
I
Or-
am looking at them as we speak, yes.
Yeah, okay. Then I will just ask our Madhu sir to present the case and maybe you can just comment. Okay, I'm sorry for that because his case is patient is in ICU and it was urgent case, so I have to include and I'm sorry for the short notice. Madhu sir, all yours. Please go ahead.
Okay. Actually, there's a 21-year-old lady who is recently married us around 6 months back. She had a history of a radiofrequency ablation of an osteoid osteoma, which was done on 5th month of 2024. She developed some complications which was treated with antibiotics. She developed a high-grade fever on 15/7. That's the last month, which lasted for around 3 days. Subsequently, she was given some antibiotic. She developed a significant dyspnea on the second day. She go back to the hospital. Her saturation was found to be very low, 85%, and she required high oxygen on the second day. She doesn't give any history of exposure. She doesn't give any history of joint pains or other disease, except for the bone problem. She doesn't have any pathology in the past. So she was seen in a major center in her place. They took a CT on the first day. They show some nodules and some ground glassing. They put her on steroids, thinking maybe it is a viral pneumonia plus along with antibiotic. But on 17th, she had a rapid deterioration. She went in for a severe hypoxemia. They couldn't maintain on NIV or other things. They intubated the patients. You can see on 18th. Actually, they thought that is probably a pneumonia. Started on antivirals, antibiotic, bronchoscopy was done. They couldn't grow. Any culture was negative subsequently. And they pulsed them with the steroids. And you can go to the next slide. She developed a bilateral pneumothorax, probably a barotrauma. She has to be intubated and then shifted to our center for further management, probably an ECMO because she was not maintained on ventilator. So this is a story. Actually, everything, she was apparently normal 5 days back. All the things happened in only 3 days gap. So when we investigated, she was anemic slightly, counts were within normal limits. ESR was slightly elevated and the CRP was increased 38. All the other parameters were normal. And I think we can go to the radiology part and then discuss, go on from there. Asmit.
Okay, so this is the CT scan that I have for a couple of reasons. I'm just struggling to get the dates of these correct, but this is from 22nd of July. And what we are seeing across here is diffuse areas of abnormality in the lungs in a bronchocentric distribution with areas of nodularity. You can see fine nodularity in the lungs bilaterally. There's some residual pneumothorax, and then you can see some linear track in the left upper. Where was the osteoid osteoma?
Isolated in the femur.
Femur. Okay. We can see this linear track in extending from the subpleural aspect to the mediastinum. And as we go further down, essentially diffuse areas of abnormality, ground glass opacities, tracking all the way down to the lung bases with dense consolidation that we can see across here. So as a picture, this is that of an acute interstitial pneumonitis. The underlying etiology one would think as atypical infection would be something one would think as first in this. And whether there is, because we've seen the previous chest CT, these were almost normal lungs. And now this is another CT, which we are seeing from 15th of August dated. You can.
So can we just go back to the presentation and then
Yeah,
discuss?
okay.
Asmita. Yeah, and then we were also thinking in the terms of acute interstitial pneumonia. We couldn't find out any particular reasons. We evaluated extensively. ANA profile was negative except for a borderline RO52 positivity. Myositis profile was negative. Anti-DS DNA was negative. ANCA was negative. And she was also evaluated by a PET scan because of the bone lesion. We were suspecting, is there any issues in the primary focus or any other things? Ortho people suggested a PET. We couldn't find out anything. Echo was showing only moderate pH. We didn't do a repeat. We didn't do a lung biopsy because she was already having bilateral pneumothorax, and we couldn't do a pulmonary function test before because she is still on high flow oxygen. So she was started on steroids. We continued steroids. Already received 3 doses. We could extubate her maybe after 5 days of mechanical ventilation. Subsequently, she was on.
My apology. I couldn't hear what you said.
Yeah. She was ventilated for 5 days, ICD removed, and subsequently, because she was dependent on high flow oxygen, we couldn't reduce her HFNC. We thought we will try IVIG because acute interstitial pneumonia and all the other things were negative. We thought we will give a IVIG. We gave it for 5 days. Subsequently, her oxygen requirement slowly came down. She was on 6 liters of oxygen last week. Now she is on 3 liters of oxygen by nasal prongs. The problem now also she is little tachypneic, but symptom has improved much. So can we go to the CT taken yesterday?
So now we are looking at 2 CTs next to each other. And the one on the right-hand side is from yesterday, while the one on the left-hand side is the older CT. And you can see significant improvement. There is still some interstitial thickening, patchy nodularity in the upper lobes as we go down. But the lung parenchyma looks much more normalish compared to before, but there's still lots and lots of ground glass change that we can see. Also, what we are seeing is there's a lot of pneumomediastinum at this point in time. There's a lot of air which is tracking into the mediastinal surface, but the lung parenchyma as such looks much better compared to before, but still not completely resolved.
So my questions to the panelist, Asmita.
Yeah. Yeah.
Should I get a definite diagnosis and go for a lung biopsy? I'm not particularly keen because now also she is on oxygen. Should we consider rituximab because her underlying lung looks like an autoimmune interstitial lung disease? Should we consider rituximab at this time, or can we wait, or should we continue only steroids along with we added mycophenolate because we can't taper down steroids, so she is on mycophenolate as well. Is there a role for antifibrotic? This is a question for Sir.
Sajal.
Yeah, patient presented acutely with fever and had a 5-day illness. And she had all that ground glassing on the CT scan. She was ventilated for a few days. It appears to me just like a viral pneumonia with ARDS. And now she has some post-ARDS sequelae, which may be in the form of some amount of lung fibrosis, and the rest of it will recover with time. So post-ARDS lung condition might take a few days to a few weeks to really recover. I do not see any reason to believe that this is an autoimmune lung disease. And no acute interstitial pneumonia will come out of the ventilator like this in 5 days without any immunosuppression. Even with high dose immunosuppression, they hardly make it out of ventilation. So I do not believe that this is AIP, nor do I believe that this is anti-MDA5 disease, nor do I believe that this is autoimmune lung disease. So there is no point of doing a lung biopsy right now, no point of giving rituximab, no point of really giving antifibrotics. We see post-ARDS lung fibrosis might in future see a role of antifibrotics, but at present we don't have any such role. And even if there's a role, it will come later in the disease if the disease does not resolve. So we had this trial in post-COVID ARDS lung disease, wherein we just gave 10 milligram of steroids, and in 6 weeks' time, most of the patients recovered, and only some of them really went into fibrosis with persistent abnormalities or progressive abnormalities, to whom we had to.
Okay, Murli Mohan sir.
Completely agree. I mean, we saw so many of almost identical cases. We are still seeing some of them. We're seeing some of them with a combination of influenza and COVID. This is very typical this is typical infection. And if you've done a nasal and throat swab at this stage, very often it's negative. We have a patient, we've just done a bronchoscopy. Baal shows evidence of COVID-19 when her nasal and throat swabs were negative. So shows evidence of influenza, though the nasal and throat swabs are negative. So I think, to my mind, this is viral pneumonia, post-viral pneumonia ARDS, unfortunate complication of pneumothorax and pneumomediastinum, which we saw so often again. So I don't think we should interfere more. You all have done a great job keeping her alive, getting her oxygen better. I don't think we should complicate the issue by doing anything more.
Rajan sir.
Yeah, I just go along with what everyone said. Nothing to add.
Okay. So
I still think we have to keep AIP in there, because I think AIP as a pattern, when you're thinking in terms of simple infection, not simple, complex infection, also influenza, a combination of what we are seeing in terms of nodules, ground glass, reticular changes, I don't think it was a simple infection. I think it was much more than that. Of course, there is probably a combination of these two together, which was happening in there. But I would think, is there something underlying, like a connective tissue autoimmune? I'm not sure. I think that's too early for us.
Mithun, are you there, Mithun?
Based on imaging.
Mithun?
Yes. I'm
Yeah,
there.
so does it ring a bell? Our myositis, MDA5 and all, but as sir told that Sajal told, there was nothing to suggest. And myositis, if it was MDA5, it should have come positive, isn't it?
Usually it comes positive, but this pneumomediastinum is
It's
a
very
spontaneous.
classical.
Usually, what I have seen is in COVID and MDA5, and any severe RPILD can have, but these are the two classical things.
Yeah.
Pneumomediastinum, still it can be like a COVID, like some viral infection causing all these things, and it can also improve the steroids.
No,
And
the
anyway,
Can I just add?
pneumomediastinum would have happened because the patient went on ventilator. You know, there are many things which would have gone wrong. We don't know. So
okay,
I don't know whether it was spontaneous pneumomediastinum.
correct.
So the other thing that is very typical is she's in hospital for a procedure, gets a problem a few days later. We've seen this repeatedly, you know, so I would just go with infection.
Sure. We
Correct.
can wait and watch.
Correct.
Yeah.
And also that,
Anyway, rituximab
I-
will be too much.
Rituximab will be too much. Okay, fine.
Yeah.
Agreed.
And so I do have a concern of continuing mycophenolate here. I'm more happy with continuing low-dose steroids rather than mycophenolate. What's the panel's opinion, actually? I have concerns of continuing mycophenolate because, I mean,
We
it
don't
looks
have-
like infection to me. I mean, my first differential, I have major concern of continuing mycophenolate.
I agree.
I think
happy
even
with the load of
steroids might not be
steroids.
required. They might yeah, they may be tapered off in the next 1 like we saw in post-COVID days, that a 10 milligram dose for maybe 4 to 6 weeks should be more than enough. I agree that mycophenolate may not be needed, but yes, the patient needs to be watched. Regarding AIP does not run this kind of a course. The clinical course does not go well with AIP or RPLD associated with myositis. They are much worse diseases. The patient does not recover like that. So I don't see anything which goes against ARDS actually and post ARDS cirrhosis. I don't see anything that goes against it.
Yes, patient improved and Madhusar's treatment worked somehow. So I think what panel says is right, that we should go ahead with Sajal's decision of giving small dose of steroids rather than MMF. And we'll go to last case of today's, and that is Sujit sir's case.
Yeah, so thanks, Smita. This is a 68-year-old man. When he first met me 2 years ago, he's now 70. 2 children, never smoker, had an advertising agency, now retired. Very mild-mannered person, cough, mild breathlessness for the last 8 months, no autoimmune symptoms. ANCA's negative, repeat ANCA, MPO positive, ANA 1 in 320, which was nucleoplasm speckle with condensed chromosomes, but this was about 2 years ago when I saw him. And we repeated the ANA, it was 1 in 80, so we didn't give too much importance to that. CCP-RF negative ACE was okay, and his myositis antibodies were also negative. But what was more important was his past history and family history, actually. At central retinal vein occlusion, 7 years ago, he was given steroids for 2 months. He developed glaucoma after that and needed a trabeculectomy in August 2018. And his elder brother was diagnosed with ILD IPAF in 2019. He lives in Melbourne, in Australia, got a lung transplant in June 22 and expired 3 months ago in May 24. So with that history in mind, and so I saw him in 22, he had a PFT of 2016, which was 2.63, it come down to 2.16. And I've been following him up, and we were really in a quandary what to do till earlier this year, because his lung functions, as you can see, were pretty much stable, though not the best of lung functions, as you can see, 48% predicted. DLCO also quite low, but that has been going on for a while. 6-minute walk test with some desaturation. So we've been speaking to him about steroids because of the central retinal vein occlusion, developing glaucoma after taking steroids for 2 months. He's very hesitant. We also talked about antifibrotics, but he said, no, if my lung function's been stable all this time. But then we did a CT yesterday, literally, because we pulled up his case for the meeting. And so maybe Vimal can show us what's been happening till now. And then I had a couple of questions.
Just give me 1 second, please.
No problem. So he's been reluctant to use steroids. The biopsy, we did discuss with him, but because of his elder brother's disease, we said no. But in fact, when I saw that initial lung function trajectory, I thought one could explain it for age, but because I think his Australian chest physician said we should start antifibrotics. And I said he's not willing, but I agree there has been a lung function drop from 2016 to 22, but 22 to 24, which is when I've been seeing him, he's been so stable. I think.
Okay, so these are the 4 scans of the gentleman, and in terms of chronology, you're looking at February 22, May 22, June 23, and August 24. So the right bottom is the most recent one. And what we can see, even after synchronizing it, you will see that the inspiratory effort or even the lung volume does look very different between the 2022 scan and the 2024 scan. And where we are seeing more and more interstitial changes, reticular changes towards the periphery. There is traction dilatation of bronchi associated with this. And as we go down towards the lung bases, we are seeing more and more interstitial changes with some subpleural early cystic changes that we can see. So there is definite progression of disease, as we have seen across the 2022 to over 2024. So now just focusing on this scan, which is the most recent scan, where we can see these areas of reticulation. There are more predominantly peripheral in location going towards with a bronchocentric pattern of disease, small central areas of sparing within this, which is in keeping with the diagnosis. It does look like a fibrotic ILD, which has progressed over a period of last 2 years.
Yeah, and actually he didn't progress much on scan, Vimal, till this scan yesterday evening. So, and Bhavin was seeing his imaging. Bhavin's has left the meeting, but he would always call it as non-IPF, non-UIP pattern. And so I was keen to consider steroids for him, even though he was unwilling for a biopsy with all his ocular problems. Would Murli or Sejal consider prednisolone or consider a biopsy here, or just treat it as familial ILD and give him antifibrotics? Because I'm going to be hard pressed to give him anything, to be honest. He hasn't been keen to take much. What do you all feel?
So if you look at the CT, it is a non-UIP pattern, and with the kind of a lot of central involvement, it goes more in favor of a fibrotic NSIP-like pattern. With the history of the brother having an IPAF-like disease. Now, IPAF is a very tricky thing, whether it just is some kind of idiopathic ILD with some autoimmune marker positivity, or is it really pertaining to some kind of connective tissue disorder in the background.
Right.
So it's always tricky, but we should, I think, he also had a 1:320 ANA.
There was one ANA that was 1:320, and it had a detailed description. When I repeated his at a lab, it came in 1:80. I can do it once more if you think it'll help.
I think we can do an NA by IF and do some ELISA ANA subtypes. So in such patients, mostly rheumatoid will not be a consideration. Myositis might be a consideration. Scleroderma. So if we look at, say, 4 or 5 connective tissue disorders, we would say rheumatoid, like not clinically overt disease, but a clinically incipient disease which might be now manifesting more in the lung. So I would say rheumatoid, scleroderma, MCTD would show up by this time. What remains is Sjogren's and myositis, which may be sometimes they may not appear, and ILD may just proceed. So an anti-Rho and anti-La antibodies with ELISA, a myositis panel may still be considered. And if we find anything there, then definitely there's an indication for immunosuppression. We can proceed with the cyclophosphamide, or we can start with, say, azathioprine or even Folitrax. If he has any kind of dry eye or dry mouth, a mucosal biopsy from the lip or a salivary scintigraphy might give you some glaucoma and he does not have a control, better that we avoid steroids, some steroid immunosuppressant, which will definitely take some 12 weeks to really start acting. But again, we are in no
Sorry.
hurry as
I
as
lost
far
you
as
for the last few
yeah.
seconds. We lost you.
Yeah,
Siddharth.
yeah.
What did you say?
Sorry,
in the last- Yeah, we just lost you for some seconds. I heard you saying if he had dry eyes, you do a lip mucosal biopsy in the lip.
Yes.
And then?
Yes. So dry eyes, dry mouth, a lip biopsy, and a salivary sample, and a Schirmer's test. So all those things we could do. And anti-Ro-anti-La antibodies by ELISA, despite NANA being borderline. Myositis antibody panel by ELISA. So these might help because we are indeed suspecting some kind of autoimmunity in the background. So these things, and then we should avoid steroids completely because he has glaucoma already, and we are in no hurry to for any symptomatic relief. He does not complain of really increasing breathlessness, which needs immediate attention. So we might start with a non-steroidal anti-inflammatory or immunosuppressive agent. It might be in the form of methotrexate or mycophenolate. Had it been a progressive disease, I would have preferred cyclophosphamide. But in this case, no. The CT has indeed progressed.
Yeah.
And had he been on immunosuppression already, I would consider antifibrotics definitely at this stage. But because of this kind of autoimmune background, it will be good to try maybe mycophenolate or methotrexate for 6 months at least to look for a change in the imaging or in the subjective kind of well-being in the 6-minute walk test, and then finally in the PFT also. So, yes.
So
those
you
will
would
be
give
my
him
views.
mycophenolate without giving him steroids, regardless of the autoimmune workup, Sejal?
Yes, yes.
Okay.
Because now we see some amount of organizing pneumonia also in the left lower lobe. Am I right, Dr. Viman? There is some patchy consolidation also appearing there.
Sure.
So, if had it been only reticulation, we would consider that it could have been an idiopathic fibrotic process. But now with the kind of OP-like pattern, if you could do that, that would be great, because that will an idea how effective could immunosuppression be. If we indeed find OP there, it will be good to know that, and then we'll be more upfront with maybe good immunosuppression for the next 6 months.
Yeah, so which is what, I think Ian Glasspool from Melbourne had mailed me saying that, look, with his brother's history, he should be, he should, according to him, he should have been on an antifibrotic 2022. And so I discussed this with him and he said, no, I don't, because I'm feeling fine. I have no symptoms. And that's where, and Bhavin was so adamant that this was non-UIP, non-IPF. And now he's progressed. So I'm in a dilemma now. And steroids, again, is an issue. I think he's very worried because he had a trabeculectomy done for the glaucoma. Murli?
Yeah, so in general, I would always go ahead with steroids, and because they will show a response in the next 8 to 12 weeks. So that is the best way to start, especially in doubtful cases. But here, because the patient is already very apprehensive, he has a complication that may get worsened, and he is telling you that he does not need any therapy right now.
Yeah.
So that's why I would say that we can completely avoid steroids, taking into consideration the patient's comorbidity as well as his own wish.
Sure.
And start with the methotrexate or mycophenolate.
Sure. Murli, any?
So I have a slightly different point of view. He's had the trabeculectomy done.
Yeah.
Hopefully he will not get will not get glaucoma again. He has worsened more recently, more rapidly. Is he going to worsen much more rapidly if we, give him the time for the MMF or methotrexate to work? We should start those, in my opinion. I think there is evidence of reversible disease, but I'm not very sure if the best way to do it is to wait. I would probably monitor his eye pressures very carefully, very quick, very frequently. Start him on the steroids and tell him, look, we'll withdraw it if things don't get better. or sorry, if things worsen. And I would probably start him on steroids with methotrexate or MMF. The antifibrotic is the tricky thing. And I think Sejal made a very good point. Is that was what his brother had truly IPAF?
Yeah.
Should we be doing the genetic test that we mentioned earlier, the Turk?
We've done.
Turk,
We have sent it.
Pepper?
We have sent it. We are waiting results.
Yeah. So I think that makes a lot of sense.
Yeah.
The thing is, we now have a window of opportunity. So I would probably be in favor of giving a short course of steroids, seeing what happens, withdrawing it with careful monitoring, and start the antifibrotic and the immunomodulator straight away.
Would steroids increase the risk of CRVO? That's the central retinal vein occlusion again, or not? Because
So it depends on what the etiology is, isn't
Sure,
it? If it's
sure,
autoimmune, then I
Yeah.
would want to probably keep him on steroids. I don't think it should increase the risk.
Sure. I'll check with the ophthal. I think he hasn't met his ophthal in a while, so maybe we'll get that review done. No, very useful points. Thank you. Thank you so much.
And further, I'd like to add a few things. One is
Yes, Amit.
MPO vasculitis. I mean, I'd suggest doing ANCA screening here as well, especially MPO disease can present like this, and with a chronic fibrotic lung disease with some small vessel involvement. And
Sure.
further, I mean, I'm for actually upfront combination of antifibrotics with mycophenolate, because this patient already lost quite a lot of lung now. I mean, lung volumes has been significantly dropped. So I'm just wondering whether there's enough time window to lose further lung. So I'm for actually considering mycophenolate with antifibrotic at the upfront therapy, because already has fibrosed significantly. These are the 2 points that I might consider upfront combination of mycophenolate and antifibrotics here.
Thanks, Amila. It's hard to convince him to take even one drug. So to convince him to take two is going to be a challenge. But I'm calling him next week to discuss all this. Thank you. So useful. Thanks, Asmita, for allowing us to get in.
Thank you. Thank you, all of you. Vimal Raj sir, Murli Mohan sir, and Sajal. Good that you make it. You made a big difference, and we hope that you come every time. And thank you, Aparna and Ritu madam also. It seems that Aparna, it is next is your turn, and I think you have seen enough. So we will be happy to have you next. Next meeting will be on 30th August, and we will be meeting at the same time. Thank you all the delegates whomsoever has joined. Anybody wants to say something, please.
Are we offline from live?
Manish, can we make it offline?
Okay, ma'am.
Sure.
Yeah, Amila, it was
The
great
good thing is you've
have you.
given Asmita